Top Med Talk.
Welcome back to Top Med Talk at EBPOM 2018. We are celebrating 20 years of evidence-based perioperative medicine this year. I am your host, Desiree Chappell, and this afternoon I'm joined by two very special guests from the conference. Ramani Moonesinghe, she is the professor of perioperative medicine at University College of London, and Anne-Marie Bougeard, she is a perioperative medicine fellow at the Royal College of Anaesthetists, and she is also an anesthetic trainee in Devon. Ladies, thank you so much for sitting down and joining me this afternoon. Thank you.
You're welcome. Thank you.
Good. All right, I'll give you guys a chance to give a little bit about your background, but I wanted to start off with you, Anne-Marie, and tell us a little bit about what TRIPOM is, what that stands for, and what you're doing in that right now. So,
okay, thank you. So TRIPOM stands for Trainees with an Interest in Perioperative Medicine. It was set up, coming up for 3 years ago now, by Sam Bampo and John Whittle, who I think you'll hear from later. And the idea is that it's a collaboration of trainees across the specialties involved in perioperative medicine to provide the opportunity to share experience, share training, knowledge, and educational resources as its primary objective. And it's really grown over the last couple of years and has representation from across the specialties, particularly strongly in anaesthesia and in geriatrics. And we also have surgical representation at trainee level. And that's been really nice in terms of shaping the way trainees are coming through to provide care across the pathway and provide a forum to talk to each other about the issues that are faced both during training, on the job, and looking towards job planning for when they become consultants themselves.
Yeah, much like Ramani. So, Ramani, give us a little bit about your background and talk to us about being a professor of perioperative medicine.
Well, I can't tell you that much about that because I'm just starting, but I'll tell you a bit about my background. So I trained in medicine first and then critical care and anaesthesia. I became a consultant in 2010 and I came to research, which is my other sort of main non-clinical interest, really quite late in my career. So towards the end of my training, I did an MD under the supervision of Mike Grocott and really enjoyed it, and then sort of set myself the goal of trying to find time and therefore funding to do research more as part of my day-to-day job. And so I've ended up now in a situation where I'm actually a non-theatres perioperativist. So my research work is around health services research into perioperative care, so looking at what benefits patients and also how we work in systems to improve patient care. But my clinical work is around preoperative assessment and post-operative care. So I've done critical care for many years, but I'm actually going to stop doing that now. But I'm not going to return to the anaesthetic room, at least not for a little while. So I hope that demonstrates that actually the role of the perioperative clinician can be really quite varied. And as Anne-Marie's already intimated, perioperative physicians are coming from a range of different clinical backgrounds, geriatrics, critical care, anesthesiology, and so on and so forth. And I think we really need to embrace that because we can all bring different skills to the fold.
Yeah, for sure. How has it been transitioning, I guess, into this space and sharing it with these other providers? How is that working?
So again, still very much learning. I've always done preoperative assessment and post-operative care in some way, shape or form because I've done clinics and I've done critical care. But the opportunity to use a real standard of care, which is acute pain post-operative ward rounds, as an opportunity to broaden out into perioperative care is a really fantastic one that my hospital has given me the opportunity to do. So I think sharing the space with other colleagues is straightforward on the whole. We sadly don't have enough, for example, geriatricians in this country to meet the need that there is to provide specialist high-quality care to surgical patients of that age. So actually there's a real imperative for us to get involved in the care of the older patients undergoing major surgery. And similarly, if you talk to most surgeons in my experience anyway, they're relieved to have the support of a multidisciplinary team to try and improve care of their patients. They're the absolute experts in the operating theatre, but outside the operating theatre, we all acknowledge that we have a lot of different strengths to bring to patient care that should come from anaesthetists, surgeons, nurses, doctors, geriatricians, a wide variety of people.
Yeah, we actually had a great conversation with Jugdeep about the geriatrician's role in this and what they're doing up at her facility.
We use age as a convenient threshold for thinking about high-risk patients, but it isn't the only one.
Right.
There are plenty of at-risk younger patients.
Oh, yeah.
So actually that again is a real opportunity for anaesthetists and other physicians who want to get involved in perioperative medicine.
Yeah.
To be able to acknowledge that and understand that.
Yeah. Anne-Marie, what's your experience been so far within the program?
Well, it's been really fascinating. Been really privileged to work at the college in helping to deliver the programme for the last year and a half. I sort of had a list of objectives of things I thought I might learn, which I have, but some of the things I've learnt and the understanding I have are things that I wouldn't have ever imagined, really. So collaboration is probably one of the most important, and I think that gets bandied around quite a lot, collaboration, but actually it is doing things like going and talking to your colleagues and understanding what they do and what their challenges are, both at sort of the coalface level when you're in clinical medicine, and expanding that and talking to your more senior colleagues at a collegiate level and at policy level to try and tease out how can you develop a program that answers some of those questions. And one of the other things I've learned is the role of the external influences on what we are trying to achieve. So we've reasonably convinced the anaesthetic community that perioperative medicine is what we need to be doing, but sometimes it can feel like you're in an echo chamber, and part of the role I've had at the college has been to see how external influences impact on what we're trying to do. When we can shout about anemia pathways till the cows come home, but unless we understand what else is happening in the world of healthcare and government policy, then we're really rate limited by that. So some of the people we've been working with have given us really good insights into how surveying the much wider scene, both in the media and general commentary, impact on how we want to deliver the pathway changes and quality improvement changes that we are aiming for. One example is getting it right first time, which I was aware of and had just published when I started this position, but it's gained huge traction in the last couple of years because of its role and where it sits in the wider healthcare setting. Some of the things we're trying to do are going to piggyback onto GIRFT just simply because of the weight of the recommendations that are coming for all surgical specialties, which have direct relevance to what we're trying to do. It's been a really interesting time, and I'm really excited to see where it goes from here.
Yeah, I have commented several times that I'm always amazed by the initiatives happening here and how collaborative a national healthcare system can be, and you actually can work in these different groups. And we were talking about NELA and Floella and EPOC and all those, and how that works together, and then this with the TRIPOM. I think that's unique and wonderful, and wish we'd have something like that in the U.S. to be able to do that. Actually, ladies, I think we're going to be pressed for time. We need to get back into the next session. It was a nice little quick session here, but thank you so much for sitting down with us. Hopefully we can have another opportunity to do this throughout the week. And please listen to the live stream on topmedtalk.com and sign up there, as well as follow us on Twitter, Facebook, LinkedIn, all your favorite social media platforms, and subscribe on your favorite podcatcher to Top Med Talk. Thank you so much.
Top Med Talk.